All right. Hello, everyone. Thanks for those of you who are here live, are watching us recorded. I am so excited to be here this evening with Aaisha Alvi, author of A Mom Like That, Memoir of Postpartum Psychosis. We are going to talk about her book, her experience, and talk about it, not just her and I, but with an amazing panel of experts here this evening. So we have here with us, we have Dr. Wendy Davis, PSI President and CEO. Oh, there we go. Thank you. We have Dr. Catherine Birndorf, a reproductive psychiatrist and co-founder of the Motherhood Center in New York City. We have Divya Kumar. She is a perinatal psychotherapist and co-founder of the PSI Alliance for People of Color. We have Emily Guarnotta. Dr. Emily, Guarnotta. She's a perinatal psychologist and co-founder of Phoenix Health. And we have Karen Wachenheim. She is a dedicated PSI volunteer who tragically lost a loved one to postpartum psychosis. So I will pass it over to Aaisha. She can talk a little bit about the passage that we'll be listening to.
Hello, everyone. Thank you so much for that introduction. And I'm so happy to be here on this panel with all these amazing experts in their own right. And I wanted to just first apologize for not being on camera to everybody for privacy reasons due to the nature of the things that I disclose in my book. Although I am an advocate for postpartum psychosis awareness, I prefer to not appear on camera and do all my work kind of behind the scenes type of thing. Nevertheless, I am super happy to be a part of this panel and appreciate you all. Before the passage is played, I wanted to provide a little bit of context to the passage because it comes from a later portion of my book and is not from the opening section. This passage is from my second bout of postpartum psychosis, which I experienced after a miscarriage. My first experience with postpartum psychosis occurred after giving birth to my daughter, but this passage is from my second experience with postpartum psychosis. This particular section relays how my fifth visit to get help unfolded. I had gone to the doctor multiple times before this visit that I'm narrating, and I was seeking help for my increasingly worsening symptoms, only to be sent home repeatedly empty-handed. In this passage, I'm going to the doctor in the company of my best friend, Zara, and husband, Adam, because you'll hear those names. I wanted to kind of situate things. I know that this passage is frightening, but I specifically chose it because I think it's so important for healthcare providers to get a glimpse into what can occur in the mind of a mom who's experiencing a psychotic episode because of postpartum psychosis, and to better understand why it's so important for everybody to know about this illness, and for everybody, not just people who have experienced this illness, but for everybody concerned about maternal health to be working toward creating greater public awareness of it. So with that, I'll go off mic.
Okay, thank you, Aaisha. Just to, again, let everyone know here, trigger warning, so the reading does contain themes of suicidal, homicidal ideation stemming from a psychotic episode. So by all means, those of you listening, feel free to mute, step away from the call, reach out to social support if needed. The passage reading will be about 10 minutes, just so those of you know if you want to kind of step out and then step back in for the conversation. So with that, I will mute myself as well and we'll play the recording. So those of you know if you want to kind of step out and then step back in for the conversation.
I wasn't sure now if my mind was merely
so with that, I will mute myself as well and we'll play the recording.
Control over it. Either way, it was wreaking havoc on me. causing me to shake uncontrollably and twitch. What happened to you? Zara asked, unable to hide her shock when I opened the door for her. I shrugged, feeling a twitch under my eye. Look, Adam's coming with us, but before he gets here, I want to tell you something, she said, leading me to the sofa. I've been researching some stuff, and it says it's really important to tell the doctor everything that's happening to you, okay? Don't be scared. It's the only way they'll know what type of medication is right for you. I could feel the sadness and anxiety rising up within me, lodging in my throat. But I'm afraid to tell them some stuff, like that my mind keeps telling me I shouldn't be near Lena. Tears splashed on my hands as I imagined people coming and removing a kicking, screaming Lena from me, whispering that I was a bad mom, even dangerous. I would never harm Lena, but my mind keeps acting like I'm going to do something to her. That's why I want medication. I want that to stop, I said. A car beeped outside. Adam had just pulled up in the driveway. I got to my feet. Tell them that. Tell the doctor what you just told me, Zara said, giving my hand a squeeze. I can't believe how fast we made it here, Adam announced as he pulled over. I'll park while you get her registered, Zara said. Taking my hand in his, Adam led me to the familiar clinic. He was back to being gentle and kind. This early in the morning, the clinic was completely empty. My feet echoed on the white laminate tiles as we emerged from the elevator. I popped my head into the reception to let them know I was there. Though the threadbare pink chairs in the waiting area were unoccupied, the narrow hallway seemed a safer place to be. I was hemmed in on all sides by crisp medical posters and stock photos of water lilies. Loud thoughts, twitches, and zaps plagued my every move. Terrified and riveted by the battle which I knew was only beginning to unfold, I felt the urge to urinate. But there was no way I was going to the washroom alone in the midst of all this. Wetness suddenly hit the inside of my thigh. A small puddle was forming by my feet. I took a few steps, watching it trail me. I squeezed my thighs together in an attempt to stem the flow. See, you are crazy, the thoughts mocked me. Aisha? Hi, my name is Dr. Robin. I'm a resident working on this floor. A petite young woman with perfectly applied eyeliner was coming to shake my hand. Resident, the thought's whisper screamed. Wow, you're lucky. You'll learn a lot today, I muttered, trying to make sure no drips were following me into the exam room. She opened a door to a small room with an incredible amount of equipment inside. What looked like an optometrist's eye examination chair was against a wall. The presence of a private washroom confirmed that this wasn't a regular exam room. Smells awful in here, Dr. Robin said, making a face as we all assembled in the room. Adam and Zara squeezed in beside the equipment. Must be from the washroom, she said, giving me a winning smile before pulling the washroom door closed. I could feel my eyebrows knitting together as I suspected she was secretly saying the smell was because of me. Who did this resident think she was? I needed a real doctor. So what brings you here today? She asked, flashing me another smile. I unfurrowed my brows. I think I've been suffering from postpartum depression ever since my miscarriage a few weeks ago, and I've come to get some medication, I announced, trying my best to rein in the twitches so I wouldn't look bizarre. I'm sorry to hear that you had a miscarriage and that you've been depressed lately, she said, scanning my file with all the notes. But you know, depression is actually quite common. In fact, I take antidepressants myself, and I've been taking them since I was 16. My jaw dropped. Pretty Dr. Robin, with her winning smile and grades good enough for medical school, was on antidepressants? Looking at her, I couldn't believe I'd waited so long to ask for medication. Mind if I do this questionnaire on you? She asked, pulling out a sheet of paper. I nodded. This was a first, probably necessary because she was a resident. As I responded to the first couple of statements as she read out, I found myself still trying to fathom the fact that this doctor was on medication for depression. She seemed so calm and functional. I couldn't believe it. I wanted to be like her. I have blamed myself unnecessarily when things went wrong, she said, reading off the paper. No, never, I said. I had no time to blame myself. I have been anxious or worried for no good reason, she said, looking up. No, never. I had an excellent reason for being anxious and worried. Wait, I couldn't help but interrupt. You're going to send me home and tell me I'm fine and handling things well, aren't you? Listen, I don't need you to ask me all these questions. The fact is that I'm sick and I need medication. I felt terror rising up inside of me at the thought of being sent home empty-handed. I've got these scary intrusive thoughts and I keep seeing these violent images involving my daughter and I want them to stop, I said, getting to my feet. Dr. Robin nodded her head. That's all a part of being depressed. As long as you don't feel like stabbing your daughter to death with a knife, it's depression. Stab Lena, stab Lena, stab Lena. The thought screamed gleefully, overjoyed at being tossed a bone. Why would you say something like that? I muttered, collapsing into my chair. Well, I think a small dose of Effexor would be good to start you off on, but it does have some side effects, and these include Dr. Robin's mouth moved up and down, in and out. For some reason, I suddenly saw the thoughts being typed slowly in my mind in courier font. Stab Lena, stab Lena, stab Lena. A long carver's knife rammed into Lena's chest over and over again, with a force so great that between each stab, her body jolted up into a semi-seated position. I don't care about the side effects, I said, shoving myself right into the doctor's face. I want some medication right now. I had no time for this lecture about side effects, not when I could see my daughter being butchered before my eyes. I'll go talk to my supervisor, she announced, giving me an alarmed look and rushing out the door. I paced the room. Lights and sirens were going off in my head, like they were alerting me to the danger of my own self. A cacophony of sounds and images were enveloping me from within, relentlessly. They wouldn't stop unless or until I did something. Anything. The window. The solitary window in the right corner of the room caught my eye. Jump, 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 the thoughts shouted exultingly. Their jubilance made me feel that jumping from the window was what I needed to do to finally make it all stop. What are you doing? Adam asked, rushing over to where I stood trying to pry open the window. I need air, I said, only revealing part of why I wanted the window open. Jump. Zara and Adam both tried to help, but it was no use. The window was rusted shut. I paced, shaking my head. I was unable to do the one thing I knew could stop the screaming, stabbing, sirens, and lights. I suddenly found my head on Adam's chest. He folded me into himself tightly. For a brief moment, I felt contained and controlled, safe. I closed my eyes. They flew open at the sound of the door. Dr. Robin stood with Dr. Bloom. I knew Dr. Bloom. She had been the one who delivered Lena. I need some medication, I screamed, breaking free from Adam's hold. Inject me with it. Stick it in me, I shrieked, thrusting the back of my hand in her face. I needed an IV drip to control the madness. Just do it to me. She wasn't like this moments ago, Dr. Robin said, clutching her clipboard to her chest. Do it to me, I continued, wondering why the IV drip wasn't already inserted. I felt a hand clutch my own before I heard the words. We can't. We don't have anything like that here, Dr. Bloom said in a calm but stern voice. I'm giving you this prescription, she said, turning my hand over and placing a small piece of paper into it. She closed my fingers over it. I want you to get it filled now and take it. Come back and see me in half an hour when you are a bit calmer. We all stumbled out of the clinic onto the street. I'll go get this prescription filled and meet you back here, Zara said, running ahead. Adam was holding tightly to my hand, giving it occasional squeezes. The cool fall breeze hit me in the face, bringing me back momentarily to the reality of what was around me. People in smart outfits, firmly gripping briefcases, raced to work. Couples crossed the clinic's busy downtown street on their way to appointments. Pregnant women waddled to their monthly appointments. One such woman with a baby bump that looked about 4 months along was walking directly towards me. Sadness welled up inside at the realization that if not for the miscarriage, I too would have been that far along myself by now. Don't be sad. Just take a knife and slit her belly open. Then she won't be pregnant anymore and you won't be sad. A hand gripping a carver's knife plunged into taut, pregnant flesh. My mouth dropped open as I realized that I was being propelled toward the woman. Tears streamed down my face. I didn't want to hurt this woman or harm her in any way. It was the devil. He was doing this to me. Fast, shallow breathing escaped me. I want to cross the street, I gasped.
Whew. All right. Well, Aisha, thank you for sharing that, for being brave enough to put it on paper and to put it out there, so that other survivors can read it and feel validated, know they're not alone, and, so that we can have a discussion about it, about some of that really scary, horrible stuff that happens. So, just upon hearing it, I'm just going to open it up to the panelists. What really stood out for you? There was so much there. But if anybody feels really compelled to just kind of chime in and let us know what really resonated with you with that.
For me, I would say, just hearing, I could feel her desperation, just continuous as she's dealing with, these thoughts in her head telling her to do these things that she didn't really want to do and begging for help and wanting just some kind of medicine to help stop it. And then thinking of, possibly jumping because that could stop these thoughts from happening and all these things. So, just the desperation she was feeling.
Yeah, definitely. I think that was really portrayed. This was a woman tormented, but trying to keep it together and kind of be there in this physician's office. So, yeah.
For me, how much we have to learn, how much we have to do, and how it's cumulative. Sometimes things that seem small are part of the remedy and the cure, and sometimes things that seem small are part of the wound and the making things worse. So I just was really feeling this time her husband's tight embrace, how important that was. It was respite. No, that's not the cure, but it certainly, for that moment, helped. But also the doctor, well-meaning, cluelessness, and not listening to the person in front of her. Even in the beautiful voice, "You're going to send me home, aren't you?"
That's what struck me too. I mean, other than just how beautifully and kind of comfortably the passage is read when there's such a stark difference between what's happening for her or for you, Aaisha, inside, like that you were desperate as Karen said, and there was so much good intention. Like nobody was trying to not help you. In fact, they sounded very caring, right? But they missed it completely. And to your point, Wendy, there wasn't a lot of curiosity. There wasn't a lot of interest in understanding what you were going through. In fact, you don't talk about any questions that were asked of you other than from a potential screener, which you wrote off, Aaisha, of being part of the, her being a resident. But the attending didn't say anything either. And it was just sort of like prepackaged and like, you'll be on your way. And I couldn't believe they let you out the door. Like, come back and see me in an hour. I was horrified. Like anything could happen. And it just seemed really scary and dangerous, honestly.
The thing that stood out to me, and I'll just echo what everybody else said too, because I was, nodding yes, but when I've read the book a couple times and just hearing the passage again, what struck me is the isolation that you experienced, Aaisha, in your pain, in your terror, in your fear, in your distress, and you're trying so hard to say that you need help. And you're holding all of this, like trying to manage just the physical symptoms that you're experiencing, seeing this pregnant woman in the street and experiencing all this and saying to Adam, I got to cross the street, how much you're holding by yourself. And you're surrounded by this husband who loves you and Zara who loves you and this doctor who totally missed it, but like, I guess she's trying. I don't know. But you're trying so hard and people are there to help and you are alone in this experience. And that to me, that pain really struck me.
I had the same reaction. I mean, the pain that you were in, Aaisha, that really comes across. And another thing that really struck me was how easy as healthcare providers it is to make assumptions. You have this woman who suffered a miscarriage and you kind of automatically think postpartum depression or post-miscarriage depression, and how that assumption can really guide how you interact with that person and the course of treatment. And how as healthcare providers, we have to be really careful about not carrying those assumptions into our work.
Sorry, is it okay if I add something?
Yeah, of course.
When I'm hearing you guys all, I just wish that you guys had been one of the providers that I went to, because I felt like just hearing you guys, like you guys like just got it, like in terms of like you're seeing like me as feeling so alone in this and kind of thing. And it's just like, I'm so grateful that there are providers like yourselves out there. And I just wish that I had one that was like you guys. So I really appreciate, your comments and everything. And it kind of like made my throat feel a little like, like emotional hearing it. Thank you so much.
Your throat might be emotional. You got the rest of us full on crying. So you are held. And we're going to say this beginning, middle, and end. You are changing the world. You are teaching us as providers. And we're so grateful for that. And this is what we wish for everybody, and ourselves included. It's not us and them, it's us and us, right? But just to take that moment to be curious, to listen. But you're changing that. This book, I already said it in the foreword. I get to say that. Thank you. This book is changing that. None of us have learned this ever, anywhere. So thank you. I meant in our medical and clinical education. We've all learned it afterwards, but not in school.
No, yeah, I'm just taking a moment to just feel it, even like in prepping what we were going to talk about and how the discussion was going to go. I didn't assume that we would all just kind of feel it, and just Divya, you said it, that loneliness, of walking into the office, begging for help, right? That disconnect of Aaisha trying to keep it together, there's so much going on for her. And what do you get, of this, I need to cross the street, or please just give me medicine. Like, that's what comes out when there's all of this chaos happening inside, just feeling that loneliness. And Aaisha, for you to be brave enough to write it, to put it out there, to read it, it's astounding. So,
and this is one of many, many, many providers
yes,
that you went to.
Yeah, I think this was number
Yeah,
5.
right. Yeah, this was provider 5. But
sorry, Aaisha.
No.
I just don't get, it just makes me so enraged that if someone tells you it's not right and you're not getting it, well, then you're not getting it. Like, in any doctor or any healthcare professional should be able to say, okay, help me understand what I'm missing, right? Like, and I know it's hard for the person who's the patient at the time. The onus is on you, unfortunately, because you're the only one that really knows how you're feeling, and you were trying so hard, and yet you were so isolated, and you don't know what to communicate other than, and you're scared to do it. What's the meaning of it? But like, there's just such a disconnect because, it's on you to have to share it, and that's really hard, but it's really on the professionals to sit with you for a hot second and just say, like, am I missing anything? Like, is there something you want to tell me? Is there anything that you can't say that I should know? Like, just any version of that you don't have to learn that in med school or any other school. It's just kind of human nature, I think. It seems super basic. I know it's not, because nobody gets it, but it's just so unfortunate that in some ways it's so medicalized, it's so boxed in. Like, the experience that you had was so prescriptive in a way that made it impossible for, like I said before, curiosity and room for you to share, for you to have space to be open, even a little, so that someone could say, I think I must be missing something, because you are asking for something that I can't give you, and I don't know why. Like, something's mismatched.
yeah, and that's why I loved one of the motherhood posts that you did, where you were just saying, like, just listen. Just listen. It's like such simple advice, but like, a lot of people could benefit from actually implementing that. And the other thing too that I just wanted to point out, if it's okay, is that me in my previous appointments, going in and actually telling doctors that I was hearing voices and stuff, and then that kind of not really raising any concerns with them, is what made me not share those symptoms later, because I was like, oh, I already brought up the fact that I was hearing voices and nobody really thought that was a big thing. So at each appointment, I left out stuff that I had said at previous appointments, because it was like, that's not an issue, And so I just wanted to point out, like the signals that you get from doctors when they don't act on information will therefore prevent you from bringing that up as an issue at subsequent appointments, right? Because I already thought, like my mind told me that maybe hearing voices wasn't right, but when I said that to a doctor, it didn't seem like that was a big deal. So at appointment number 5, I wasn't going to talk about the voices I was hearing anymore, because I got the message that that wasn't a concern, right?
That's so powerful. It's not just being shamed or scared when you report, it's also being dismissed. And I think all of us remember that from our postpartum experiences, or any medical appointment. You're like, I guess that didn't matter. I thought that was like, I feel like really important, but they acted like it was normal. That's so powerful. And I have to say to people listening, if you're relating and you're in the middle of this, whether you think you might be experiencing this, or your family trying to figure this out, you are not alone. We are right here, and we really have the resources thank goodness. You can call, text, English, Spanish, web form, whatever you need, to say, I'm not sure what's going on. But if you're struggling with like, that's my doctor, I just had that yesterday, please contact PSI, because we'll help you get the words ready. We'll help your family, or the maternal mental health hotline in the United States. You really don't have to do this alone. And Aaisha, you are changing that too, that representing in your beautiful book, I'm just going to hold it up again, A Mom Like That, that resources are here and people don't know. And I just couldn't wait to say, please contact us if you're in the middle of this, or you went through this and you're still grieving, you're still scared, or worst, you lost somebody in your family. Please just contact us. We are really here to help you through it.
Yeah, thanks, Wendy. You know, and to even piggyback on that, I know that we had put them up in the chat, you know, or kind of in the comments at the bottom. You know, PSI, we have a Get Help page for postpartum psychosis. Goes a little more into, you know, kind of potential symptoms, what it might look like. You know, there's the crisis kind of line at the bottom. There's the maternal mental health hotline. We also have a new postpartum psychosis discussion tool. I'm going to plug this right now. We just published it a couple weeks ago. And so it is a product of multiple other survivors' experiences, very specific descriptions of what symptoms looked like, felt like for them. And also collaborating on that were other physicians and psychiatrists. So it is a wonderful tool. As Wendy had kind of said, if you're thinking, oh gosh, this might not feel right, or what's happening, what's going on with my spouse, with my loved one, it's a great tool to go through and see, you know, potentially, could it be a symptom of psychosis? Again, it's not like a validated screening tool. It hasn't been, you know, given to a randomized sample of people, but it is a tool that really uniquely has that piece of lived experience of this is what it felt like and looked like for me. And then also the professional kind of collaboration and backing. So that is on our website and it just got posted. It's the discussion tool. So it is in English and Spanish. I wonder, in speaking of this, of just like questions, what's happening, being curious, in your passage, Aaisha, you know, the resident, the physician, they didn't talk to Adam or they didn't talk to Zara. They were there with you in the appointment, you know, and Dr. Birndorf, you talked about it, all that onus being on the patient. Well, I think even in this situation too, right? Like it doesn't have to be like that, her spouse, your best friend can be called in and they weren't. And I want to ask, you know, Karen is somebody who was a family member, you know, not like a spouse. I know you weren't living with the person at the time, but as a family member, what your reaction is to this, to family not being brought in.
Yeah, I truthfully think that's a huge mistake to not have people that are closest to you being brought in because they are the ones that are seeing what's going on. So maybe things that the patient, you know, the things Aaisha wasn't speaking of, or somebody else, you know, like in Cindy's case, you know, I lived 3 hours away. Her other sister lived 3 hours away. Um, you know, and so we weren't there, but we could have been on a phone call from the doctor to say, what are you seeing going on? You know, she never actually believed she had postpartum depression or psychosis because she didn't start having symptoms until 4 to 6 months after. So when we tried to, you know, tell her we think she did, she's like, oh no, that only happens when you have a baby, right when you have the baby. And, you know, in her case, you know, she believed that my nephew was brain damaged and that it was her fault. And she was seeing all kinds of strange things with him. And so she definitely admitted she was depressed and she was seeing I don't know if it was a psychiatrist, whatever it was, a therapist, but not one for postpartum. But again, even in that case, I just feel mental health in general, if somebody's really struggling, why not talk to their loved ones and see again? Because maybe if we could have said, like, we're really worried about her, she is the one who was always contacting us as a family members, and we're barely hearing from her, and she's, stopped talking to friends, and she's isolating herself in her apartment, and, just different things that we have no idea what she was saying. So I think it's important because I think that could really help the, doctors to really figure out maybe what's going on with that person if they, can talk to people who are around her.
I try to almost, invariably have a family member or some kind of collateral, right? Somebody who can say, is this how she normally is? Like when she's well, is this what you see? Is this how you know her? Right? I mean, you can ask that on the phone, you can ask that in person. And during COVID, when we had to do everything on screen, we got the family even easier because they were right in the background. So that was like one small bonus. But you have to use everybody you can around to understand what's happening. Because like Aaisha said, she's not going to tell us stuff that's happening because she's been dismissed. It was not useful information. She didn't think it was important, as evidenced by what those around were transmitting. So it was important to hear from others. And it's such a missed opportunity if you don't have the family involved.
Mm-hmm.
Yeah.
I think families can be one of the most valuable sources of information. I mean, what you see with a patient or a client in a 15-minute appointment or maybe even a 45-minute appointment can be vastly different than what's happening at home. So getting that collateral information and also speaking with other healthcare providers, coordinating care. This was provider number 5, and contacting those, getting that consent to contact those other providers can also provide really valuable information. So I definitely agree. Definitely a missed opportunity.
And it's an opportunity for family members too to get valuable psychoeducation about what might be going on with their loved one, why they can't be left alone, the importance of taking medication, all because the illness is affecting everybody in the family system, right? So it's it's such an opportunity for everybody to get care and ask questions.
And I wonder if, not just for that initial assessment, but for ongoing sort of treatment planning, how often, maybe Emily, Catherine, Divya, you see that in your practice, because I think a lot of times when an individual that's experienced postpartum psychosis becomes ill, there's the insight very much waxes and wanes, or for so many of us, it's gone. So there really is a reliance on the people around them to kind of know when it's time for treatment to take another turn or to bump up. So I don't know if even for ongoing treatment, that's something that you do and, is done.
Yeah, for sure. I mean, we at the Motherhood Center, we right now in our partial hospital program, we have 7 women with postpartum psychosis. So talk about not being alone. So they're at some place in their recovery, having been in the hospital or having been stepped up from outpatient because somebody recognized that they were not doing well or were not responding to treatment. And we involve, some are still being escorted to the center. We're not a locked unit the way a hospital would be, where you really need that safety in the most acute moments when there's imminent danger or concern about it, or someone have really lacking insight and judgment. But when they step down to us, we're the next level of treatment outside of a hospital. we do have a locked door, but you can come in and out, right? But we have the family escort people, not because, they couldn't get there on their own, like logistically or something, but because it's to accompany them in this journey where they may not know how unsafe they are or what might happen, what voices might say to do, or, how active the disorder is, right? The illness. And again, if we're so worried, we have somebody in the hospital, but we still, when people just come out of the hospital, we say to the partners, to the families, we have everybody in the room, and we say, we really want you to we want you to have others with you at all times. And we don't want you to have to be alone with the baby, because at the moment, it's just a lot when you're trying to manage, you're trying to get well. And we want to take that off your plate. So we have lots of different ways to talk about how this is meant to be supportive and helpful, not punitive, but that we're going to employ your family, and we need the buy-in. So to your point, Divya, the psychoed around like, let's help you understand this, because 1 minute or 1 hour, she could, again, sound very much like herself. And Karen, I don't, my guess is that your sister-in-law, plenty of times seemed perfectly fine. And that's what's so confusing. I mean, this is not the simplest of illnesses to understand or to get. So I have, not everybody understands it as well as everyone on this panel, right? But we really need to educate the family, to educate the other providers who may or may not have recognized or noticed, and then to really create a treatment plan and system for how we're going to manage this at each stage of recovery until someone is truly well and back to their own self and baseline and independence and able to, care for themselves and the baby again. So it's a process, and there are steps along the way to make sure that someone's safe and just, since we haven't really said this yet, so treatable, so treatable. Everybody gets better, right? Like if you can get the treatment properly diagnosed and treated, everyone gets well. So it's like, it's one of those things where you just scratch your head all day long, because, everyone on this, we can help you. And it's not rocket science. It's just not. Diagnosing it, recognizing it, having the psychoed for the family, getting everybody, that's the rocket science. That's the hard part. The treatment, we can get you treated.
Temporary treatable illness.
Yes. Yeah. Yeah.
Yeah. It makes me think, there's another provider, practitioner, very involved with PSI, Chris Rains, would always talk about, she had a patient where, again, this spouse, and people are smiling, I don't know if you've heard the story or not, but I love it. This spouse was so involved in treatment that as soon as his wife, who had experienced postpartum psychosis, went to the grocery store, she bought 2 pints of ice cream instead of just 1. And for him, he knew that meant, he had called Dr. Rains and said, I think she's slipping into psychosis again. She bought 2 pints of ice cream and not 1. And so I think just to be that clued in with the family and she then came in, she saw this patient, turns out, yes, she was, slipping back into psychosis. They were able to catch it and treat her. But just what a process it is, and, how important it is to keep family members involved. And I think it's also, that being said, so important when we're talking about this for family members, those around the individual, right? If they're doing something that seems odd or unusual, like, say something, reach for help. That's why we're here at PSI. It doesn't have to be anything even specific. We just gave the example of 2 pints of ice cream and not 1. If there's unusual behavior, reach out to your significant others, to their primary care, to their OB, to us. We can kind of help support you and figure out, it might be nothing, but what if it might be. So
I just want to say really quickly, the other thing that actually highlights, without saying it, is it's not that Julia's saying it's the 2-pint of ice cream diagnosis. It's this. The relationship between the family and the provider was already existed, even if they'd only seen Chris once. The point was that she's a trained perinatal mental health provider. She got the risk factors, the history, the relationship, the rapport. And so when he called and trusted his provider, their provider, Chris knew all that. Where, yeah, usually like 2 instead of 1, you would think maybe she's PMS, like what? But Chris knew it's the perinatal period. She knew the history. I don't know Chris's case. I'm just saying that's what happens when you really fully train providers. And Catherine, thank you. It's not rocket science, and it doesn't take forever. We have experts that can train you to make these assessments. But that relationship, Julia, that's what we all know, and we were heartbroken, even knowing the story, to hear you again, Aaisha, to say you were yearning and searching and trying to find that relationship. Just listen. So just thank you for that. So Chris knew 2 pints instead of 1 meant something to them. And it was a risk. It was a sign of risk.
Yeah.
Anything out of the ordinary. I also want to just say on the 2 pints of ice cream, right? If this person only ever bought 1 pint, but 2 pints was the sign, right? Because again, it's there's so many things about that example that are terrific.
It's kind of funny. Like when you guys are talking about ice cream, there's like a Cinnabon scene in my book, because I love Cinnabon, and my husband tried to cure me with Cinnabon, and he was just like flabbergasted that the Cinnabon wouldn't work. He made me eat 2 of them. I probably got like 3,000 calories in that one visit, but so for me it was an ice cream with Cinnabon.
I love that. Such a great example of your favorite thing that you couldn't even touch.
Yeah. Now, again, bringing in the family, so important, was missed. I also, again, in thinking that this is Aaisha's 5th visit, knowing that she is not of the same ethnicity or culture or even religion, perhaps, of her providers, in this specific passage. So again, that wasn't stated specifically in this passage, but those of us who have read the full memoir know that Aaisha is of a different race, culture, ethnicity than a majority of the providers that saw her. How much that comes into play in this example in Aaisha's story.
I could talk about this all day. This is why we created the Alliance. I don't know if y'all can see, because I've got my Alliance. And I can talk more about the Alliance at the end, because I know there was a question in the questions you had prepared, Julia. I just want to say first that I'm not inside the minds of the doctors and providers who treated Aaisha, right? So I don't want to totally make assumptions. And also, I think it's important to look at what we do know about BIPOC, Black, Indigenous, people of color, when it comes to perinatal mood and anxiety disorders. Also keeping in mind that BIPOC are not a monolith, right? Whenever we say BIPOC or communities of color, I also kind of want to go, ugh, because we need a lot of more research disaggregating those things. We can't lump us together because we're not all the same. Disclaimer. But we know that women of color experience PMADs at a higher rate compared to white women. And we're also less likely to receive treatment, even when we seek it out multiple times. Aaisha hammers this point home in her book, which you absolutely should read, and I can't stress it enough. We also know that folks of different backgrounds, different cultures, race, et cetera, may express or describe their symptoms differently. So again, like we said a minute ago, providers have to be open. They have to be humble. They have to be curious. They have to ask questions. When you say you're depressed, can you tell me what that means? What does that word mean to you? Just so I'm sure that I'm understanding you correctly, right? specifically with the interactions that Aaisha had with her providers, what might the difference in ethnicity, culture have done to affect her care? I would want to know, had the providers that she'd seen ever worked with women of color in the perinatal period? Or was this their first time? Did Aaisha's symptoms, did her report of her symptoms differ from clients that they had treated in the past? Did they make assumptions about her presentation, about her mental state based on her race and culture? Did they make assumptions about her based on some preconceived notion about what they thought about Desi women or Muslim women? Did they have ideas of what Desi women, Muslim women are supposed to be like? Were they patronizing her? Were they disbelieving her? Did they assume that she was educated? And I'm using these terms very loosely, right? Educated, articulate, put together. I can't help but wonder about the role of the model minority myth, right? Everybody's got this idea about folks of Asian descent, about what we're supposed to be like, what we are and what we are not. How did those assumptions influence how her providers reacted? We also know, and she mentions this too in her book, she's got to read the book. She talks about how providers don't always trust women of color, especially around things like pain or distress. They might not trust us. They may think that we're drug seeking, that we're malingering. We don't know our own bodies. We're not reporting our symptoms correctly. But when she says, I want to be hospitalized, I want medication, why did people not listen to her? And we have to think about what role race and culture played here. The other thing I think about is when I read her story, I had to wonder, what would this have been like if she had seen providers of color? And I say this because the statistics that we know about Black women and Black babies have reduced mortality rates, which is to say that they are less likely to die in the perinatal period when they're treated by Black doctors. That research is, that's profound, right? And we need more of that research applied to different groups, ethnicities, cultures, and specifically around perinatal mental health too. What does treatment look like? There's a part in the story that Aaisha didn't read. She's not reading it here, but I just want to mention because I think it's important. She talks about wanting to see a Muslim doctor, and it was part of the delusions that she was experiencing, delusions being beliefs that are not based in reality. And also, I just have to wonder, what if that had been a choice for her? What if she had seen a Muslim doctor, right? Would she have said something differently? Would the Muslim doctor have treated her differently? We don't know. I wonder, like, if that had been a choice for her, would the treatment have gone differently? But ultimately, I come back to the statistics about Black doctors treating Black mothers and babies. And that research is profound. And one of the reasons why we created the Alliance is because we need more of us. We need choices. I'm not saying that I would be the perfect person to treat Aaisha because we share a skin color and a country of origin. No. But for just everybody who's suffering to have more choices around the treatment that they get. And also, oh my God, bias, all kinds of education. She mentions in her book too that at the time, all the women that she saw in materials about postpartum depression were white women. Did those doctors only see white women in their offices? We don't know. So I have lots of questions. That's what I think. Sorry, I just talked a lot.
No, Divya, I wish you would have gone slower and let me take it all in, because there was so much there. Oh my goodness, I didn't know the statistic or the study about Black doctors and then the influence of, infant mortality, seeing doctors of their choosing. So yes.
I knew I was right in asking that Divya be on this panel. Thank you, Divya. You touched on such important things. If I could just highlight one thing that Divya said, I think that when I went in, there was a lot of times when I was quoting passages from scripture. And I think that maybe had I been seen by somebody from my own background, they would have been normally, I'm Muslim. Normally Muslim people don't go around speaking in scripture. And I think that maybe that would have immediately alerted maybe a Muslim doctor to the fact that something was wrong with me. Because I know in hearing stories of other women, when other women who are of Christian background have quoted biblical verses, it's really easy for the doctors to clue in on the fact that this person is like, probably delusional. I was quoting scripture from the Quran, which is not something I normally walk around doing. You know what I mean? So, but obviously none of the doctors I provided, recognized that that's what I was quoting, even though it was kind of archaic language I was using, but still they didn't recognize it.
Right. That's what I was thinking, right? That like if a Muslim doctor, they'd be like, this is not usually what we do. And I also want to point out like the geopolitical time context that this was shortly, like it was like mid 2000s. So like soon post 9/11. And I just want to name that too as a thing that happened to brown people, and like the judgment and biases. And I say this, I'm not Muslim. Just the judgment that South Asian people experienced. I have to wonder what role that played. And I just thought it was worth mentioning because of the time.
Yeah, for sure. There was a lot of negativity thrown at like all people that seem to resemble that, group. And it wasn't just Muslim people, a lot of like Sikhs, people of Hindu background, and everybody were kind of getting smeared with negativity, right?
Right, because we're all the same. Nobody can tell us apart. We're all bad. We were bad then. Anyway, I digress.
Yeah, I'm just still taking it all in. I don't know if anyone else has responses, thoughts, sort of about that. Divya gave us so much and was so eloquent. Yeah, Catherine.
I was just going to say, we can't always know, even if we do look alike, culturally, we may still be different in so many ways. I mean, we all are individual and have our own experiences. So again, and I think what you're saying, Divya, is so important, and so important for us all to learn about and to check ourselves and to understand better and to take that into account when we see or with patients who look different from us. And again, I think we can say, tell me about yourself, like what am I, is there anything, what you're saying, is that traditional, just like, again, to clue into the, like, that's what we're taught in this field, right? You clue into what's going on in the room, everything, if there's markings on the body or just the color of things or tattoo, whatever there is to say, like, tell me about that, or tell me about your experience, the words you're using. I don't recognize those. Talk to me about that. What are you saying? And to ask a partner, is this, scripture that is being recited, is that traditional? I don't know. Humility and really just back to curiosity, because we're not going to know everything. And I wish that there was more representation, and we, it would be wonderful to have, and if we, as we move towards that, because I'm hopeful that we will have it more and more, that along the way we stay, to your point, humble and curious and inquisitive, and again, you don't want to burden the other person, tell me, like teach me, but definitely if you're in the room with someone who's espousing things that you don't understand, ask about it. Try to understand the context in which they're talking to you about things that they are presenting with. And call for help. I mean, even though I'm Jewish and I've treated many Jewish patients, I've had to call rabbis many times to say, I don't think this is right. Like, this is not what I know to be true. And I'm not religious, but can you help me? And I've had rabbis say to me, oh no, that is not within the context of routine orthodoxy. I'm like, okay, because they told me it was. So now I have the context, right? Like, call out, find the people who can help you with whatever it is to understand better what you're seeing in front of you. And is it in context, or is it outside the context? Because it might not be your context, but it might be theirs.
Yeah, so important. Thanks. Divya, did you want to take this moment to plug any kind of resources or tell us more about the Alliance and what you guys are doing to, kind of bridge this gap? Oh, you're on mute. There you go.
I would love to. Yes, I was just reaching for I was like, taking a deep breath. So the Alliance, I co-created the Alliance with Jabina Coleman and Desiree Israel. I want to say their names out loud. They're so dear to me. It was created in 2017 because we saw a need for an organization that was focused on perinatal mental health and integrated racism and oppression and culture and all of that, where our lives were not sidebar issues and we weren't a slide or bullet points on a slide in a presentation on perinatal mental health, because as we can see, we can't separate those things, right? It is how we walk through the world and it is how we experience life and mental health and perinatal mental health. And so it's an integration of all this together. It was created to expand capacity and reach of the perinatal mental health field in order to better support folks, families, communities of color. And we want all birthing folks to see themselves represented in the perinatal mental health field. So they have choices and information regarding perinatal mental health. So much has grown. There's so much since we started it in 2017. So just quickly about specific things that the Alliance offers for survivors and help seekers. There are all kinds of peer support groups, you name it. There's a support group for so many different race, culture, ethnicities, backgrounds, specifically around loss, birth trauma, a lot of different types of experiences that you can have in the perinatal period. Some groups are done completely in Spanish. There's a provider directory that you can search for a provider with certain demographic information. There are peer mentors. And basically everything that PSI offers, all of the support resources that you can find online, have Alliance members integrated throughout. So wherever you go to find support within PSI, you can find Alliance members if that's a person that you want to connect with. There's also Connect, PSI's app. You can use that also to connect with all the support resources that PSI offers. Your local PSI coordinator will be able to connect you with local Alliance members or providers of color if that's something that you want. And if you are a professional listening in, a part of what the Alliance is doing is building the pool of professionals of color, because like I said, I will say this every time somebody gives me a microphone, we need more of us. And in order to do that, the Alliance provides scholarships for providers of color so they can attend the PSI conference, the trainings. There's there's mentorship programs for folks to take the PMH-C exam, also folks who are starting professional practice in the field. There's a mentorship program. I just said that because I have a list of things that I don't forget because my brain will short circuit. And also there's this really cool offering where there are research fellows doing research on specific topics so we know more about us so we can better support us. Did I miss anything, Wendy?
Thank you for asking. I'm going to say, no, you didn't miss a thing. And thank you just for sharing that with all the spirit that you did. And just come to postpartum.net and look at the Alliance. And I appreciate one thing I'll say to echo what Divya is saying. First of all, thank you for founding the Alliance. Thank you for honoring PSI by becoming part of PSI. And so importantly, in planting that seed that's now grown into a beautiful tree. And as Andrea Clark, who's the director of the Alliance, said when she first started, oh, we don't want PSI to have a safe space for people of color. We want PSI to be a safe space. And that sums up kind of what you're saying, Divya. It's not next to, it's not a check mark. It's not a one slide. We want this to be a trustworthy space. And so just thank you.
Oh, well, thank you, Wendy. We're here together because of all of us, right? And I just want to say too, that again, if you're a person of color and you're struggling, I'm not assuming that you want to talk to me. I will never assume that. You should talk to whoever you want to talk to. And also, I will say that when I was in my hot postpartum mess, like it would have been easier for me to call somebody named Jyoti or Sakina or Jabina or Marisol. Like I would have felt more comfortable picking up the phone if I saw a Black or brown face that I could talk to. If that's you, great, there are options. If that's not you, great, there are those options too. Options.
Thank you.
Yeah. Options. I love it. Well, thank you, Divya. We still have, I love that we have 90 minutes, so there's so much that we can touch on within this passage about the topic. I want to shift just a little bit now toward the part of the passage where Aaisha was given a screening instrument, we can kind of assume. So she was asked by the resident, some of those questions that we see in the very typical kind of depression screeners. And Aaisha gives us the questions, her interpretation of them, and then her answer. And we see kind of the disconnect in there and her very illogical logic of how she answers things and why. So Emily, I wanted to ask you, can you speak a little bit about the use of screening tools in the perinatal population, specifically for postpartum psychosis? What's the utility of those tools? What are their downfalls? It's kind of what we saw in this passage.
Yeah, I'm so glad that you asked this question. So unfortunately, there are no screening tools specifically for postpartum psychosis. So I'm assuming that Aaisha was given something that's typically used for postpartum depression, the EPDS. Screening, it's really important and it can be really helpful. But I also think as perinatal mental health providers, we also need to know when to put the screening tool to the side and just have a conversation with the person. And the way she described in the passage that she was answering these questions, and I'm assuming she was, her hesitation or her apprehension was probably visible to the provider. I think it was, again, another missed opportunity to say, I might need to put this to the side and I might need to just sit with this person and ask them questions, and we might just have to have a conversation. Because I think screening tools can be very helpful, but they're not enough on their own. And I always tell people that it's not just asking the questions or giving a screening tool, it's providing that safe space so that person can really tell you what they're actually thinking and feeling. And if that safety and that rapport isn't there, then the screening tool or asking the questions is not going to be provide any value at all. And that was clearly missing in the interaction with this particular provider, number 5.
Yeah, thanks. I don't know if anybody else had thoughts about screening tools, about how it was used in this instance. I think, Emily said it beautifully and echoes a lot of what Catherine said, right? Like, it doesn't mean anything if there's no rapport. And it's really about asking the question and really being curious and not being, and I think as so many providers, not being scared of what the answer is going to be, like as a provider, right? Feeling comfortable, like wherever you take me, I'm okay going there. Not because I need to get home for dinner it's 4:45 and I really need to leave for my kid's recital, or I have 15 patients after you, but like I'm here for it and I'm ready to kind of go there with you.
Ready for the answer. Again, because we're right here. Sorry, but we have a maternal mental health hotline in the United States. Providers can call. We're going to focus on providers for a second.
I love it.
Providers can call in a hot second. The average length of time to answer those calls and texts right now on the hotline is 20 seconds. PSI is here for providers and families and help seekers, but providers can call, prescribers can get a consultation about medication. So like we say to help seekers, you don't need a diagnosis to reach out. We also are saying the same thing. And Emily put it so well. Providers don't need to it's hard to be humble, right? Catherine, you were talking about that. Providers don't need to know what to do. They just need to know where to go to ask someone for help themselves. And so the provider doesn't need the perinatal mental health education to know, like, I could just call Postpartum Support International or the hotline, right? And see, what am I looking at? this looks like an emergency. What do I do? And I wouldn't say this out loud in public if we didn't have the capacity to deal with it. We want people to contact us. And we will teach people how to do screening, but more importantly, Emily, you summed it up for all of us, which is why none of us had anything to add, except resources that I'm adding, is that it's a conversation.
You know, and I just wanted to throw in as I was thinking, I'm not a provider, but thinking on the other side of it, like I love the idea of trying to build that rapport because, you know, if you're sitting there with a doctor you don't know, you don't feel like you trust, how honest are you going to be when you answer those questions, right? You know, like I go into the doctor's office and I get a, you know, screening every time, just a checklist to, you know, and I'm just like, yeah, whatever, you know, but you know, if it's somebody that I know and trust, I might be more willing to be more open about what's really going on. So I think that's really important, really important.
I would add that if anybody is listening here who is a doula or a lactation professional, somebody who does home visits, that you've seen clients, patients multiple times, that relationship is there. And one of the things that I do professionally is I do a lot of trainings around PMADs for other birthing professionals, birthing postpartum professionals. And I'm like, you have that relationship with somebody, right? You might have, if you've been at their birth, you're doing a postpartum visit, the lactation person's come a whole bunch of times. You have that foundational relationship. And like Emily said, that relationship is everything. And if you're asking questions in the context of trust and rapport, that conversation is going to go differently. And even if you're meeting somebody for the first time, this, you know, like Catherine said, it's coming back to like clinical skills 101. The relationship is the primary intervention. It's the context where everything else happens. And so if we can focus on that, and if you're somebody who already has that with clients, you are in a really great position to ask all of the questions and receive the information you get.
And just to say, to Wendy's point, I mean, PSI has everything you need. So it's like, it couldn't be, it wasn't always there. Like now it's even made simpler, right? Like it's kind of the answer to everything. I'm not saying it's perfect, although I love PSI, but it pretty much has everything. So you don't have to know anything. And I think I can only, as I represent the medical field, I think I'm the only one on here from this particular field that doesn't happen to be the most humble, or certainly doesn't like to not know. I mean, doctors like to know they won't ask a question that they don't know if they can't have an answer ready for it. So people don't ask the questions because they don't know where to go with an answer. Like if you ask an open-ended question and you get someone to talk to, first of all, it's going to take too much time and you don't have it, you're not getting paid for it. And two, it's going to be, what if it's something you don't know the answer to? It is so uncomfortable for medical professionals, and I'm making a huge generalization, but I'm still making it. And the truth is, you don't have to know anything. You have to know PSI's phone number. It's like, you know, or just a reference or resource. So again, it just is education, advocacy, the kind of work that everyone here is doing is so important to get the word out so that people know where to turn. And it wasn't always so robust and so big. And now it has just got layers upon layers of resources that make it an incredible organization to get the answers you need.
Thanks. Yeah. Aaisha, did you have anything else you wanted to kind of chime in or respond with your kind of relationship with the questionnaire?
Yeah, first I wanted to say, Dr. Birndorf, I've been agreeing with everything that you're saying, but I'm going to correct something. PSI is perfect right now.
Oh, sorry. Okay, I'll join you. I don't love the word perfect, but I'll go with you.
Because I really do agree with what you and yourself and Emily was saying in terms of like providers, I think are really scared to ask a question that they are afraid might take them into territory that they don't really know about. And I think that that's why I'm really big on spreading awareness of postpartum psychosis, because I think that that's why the providers were scared to really talk to me, because they were like, maybe they had a feeling that like maybe I'll be delving into territory that I don't know too much about. And we don't want that to be the case. But now we also have PSI there, which can direct people when you find yourself in that position as a provider. But one thing I did want to point out is that although I completely agree with Emily that, you know, in this particular appointment number 5, or we'll call her provider number 5, she just needed to have a conversation, and that wasn't really the best time for the questionnaire, especially since this was like my 5th visit. I do want to point out that this was the only provider that even bothered to do a screening tool on me. So had this, I mean, at this point, I was so far gone into my psychosis that that's why I was like misinterpreting everything that was being asked on the screening tool. But had this screening tool been used at visit number 1 or 2 or even 3, because I was being honest about all my symptoms, it would have really worked. They would have recognized how severely depressed I was and likely hospitalized me at that point. And like my own perinatal psychiatrist said to me, had they screened you at visit number 1 or 2, maybe because the version of postpartum psychosis that I had was major depressive disorder that developed psychotic features. She said, your depressive disorder might never have even developed psychotic features had it been caught at that earlier phase, right? So I do think that their screening tools are very important, but I agree completely, Emily, with you in the sense that being visit number 5, like a conversation, especially with the way that I was like acting and being like, oh, like kind of like frazzled and stuff like that, would have been more appropriate. But I did want to point out that fact that screening tool would have helped so much if that had been administered at appointment number 1, 2, 3, or maybe even 4. Thank you.
No, thanks. I think it all just comes back. Oh, sorry, Emily, you go. Go, Emily.
Sorry, I was just gonna say that's a great, that's a really important point. I think screening is definitely very important. We should still ask those questions. It's just being able to, it's a delicate dance as a provider of knowing, asking the questions and then knowing when to shift and when to pivot. But you're absolutely right. Those questions should be asked every time. And you're right. It could have caught something prior to developing psychotic features. You could have caught the illness sooner and had, a much different experience. Well, thank you for adding that.
Yeah, thanks. I think what we have been talking about with that kind of just open, being curious, creating that rapport in the relationship. If, even as providers, that's the line that you're taking, it would kind of answer this next question. But I think there's such it's so apparent here that we should still talk about it and ask it. That being said, so Aaisha tells Zara in the passage, she says, I would never harm Lena, but my mind keeps acting like I'm going to do something to her. So upon hearing this, a provider might be inclined to just determine that this is an intrusive thought, and I think, that she doesn't want to, but these thoughts are coming up for her that it is, that then they would stop there. Perhaps this is an intrusive thought, even the provider said, oh, it's just depression, unless you're having these kind of thoughts. And then that's when the hallucinations sort of came up for Aaisha. But, what are the potential consequences of a provider, kind of thinking, all right, well, she doesn't want to harm Lena, but she's having these thoughts. It's not psychosis. So I don't know if anyone wants to speak to that. Yeah, Wendy?
I'm going to let the other clinical providers speak up, but I do want to say that this is the most important clinical pearl of wisdom that has changed how PSI, and hopefully a ripple effect, but how PSI teaches providers and families about postpartum psychosis. This is it. And as I say in the foreword, Aaisha has changed that in her writing. and other advocates in our postpartum psychosis task force have helped PSI realize, by the way, if you've been in this field for more than 5 years, you learned it incorrectly and you taught it incorrectly, and don't just move forward. This is it. There isn't anywhere where we should say, but see, you're telling me and you're worried about it. So so then I'm not worried about you ever again. You have to go one step further. So I just want to add that the element that this is learned from individuals with lived experience to say, please stop teaching it that way. Even having advocates in the middle of a conference call me and say, tell them to change it. And we did.
That's so good, Wendy.
Because I called Bertie Meyer and I said, I know you're in the middle of the conference, and it was online. I said, you have to add what we know. And she did. So does that make sense? And then I want to go on, but to say PSI has already changed what we taught, and we've already processed and continue to process the number of years where we got it wrong, that you can have anxiety and intrusive thoughts, and if there's no delusions, psychosis, bipolar history, et cetera, yes, it's an anxiety symptom, OCD, but you can have psychosis with intrusive thoughts. And you can go to your provider and your ER and say, I need help. Your passage described it perfectly. Sorry.
Yes. I just want to say yes 1,000 times over. It's I've taught it for years, and it used to be I would get the call from the ER, and they'd say, I'm going to hospitalize this person unless you tell me they can go. And I would say, well, what are they saying? Talk to me, so if I was the attending on call, or I'd go in, whatever. And they'd say, they're so scared they're going to hurt the baby because they're having intrusive thoughts to hurt the baby. And I would say, well, if they're scared, then they're probably okay. Or we used to say, they're safe, right? And forget it, or wipe that from the, I couldn't believe it when it started to emerge. And I saw it from lived experience, from the patients I was treating. I learned that, and you can learn the hard way, which is dangerous things can happen when you miscalculate. But the truth is you have to always take it seriously. There's no more us trying to a provider trying to parse out if the person's going to act or not act. The lines are obscured. It isn't clean anymore. Like, on one side is OCD, without psychotic thinking, and, because they're scared, right? It's ego dystonic. And on the other side, there's a psychotic thinking that's out of touch with reality, which is ego syntonic, right? It meshes with how the person thinks about things and themselves, right? One seems to be part of the reality. The other, they know it's not part of the reality, but they can't stop it. That line is no longer the line I used to really hold dear, because it would help you decide if you could let someone go from the ER, right? If you needed to hospitalize somebody, or if you could let them go home. That's a big line, right? And we used to hospitalize people who didn't need to be hospitalized, but you know what? Better, God forbid you miss something. And again, I'm not saying hospitalize everybody. I'm really saying it's much more nuanced than we ever knew. So I will still say to people, and Wendy and others can correct me if I'm saying this wrong, but the way I think about it now is, generally speaking, if someone is scared to death of the thoughts they're having, and they would then can say, I would never act, I will say hopefully that will never happen, but that line can be crossed, and you have to know that can happen. So it's complicated because it's not clean anymore. It's not, we can't be reductionistic about it anymore, which felt really good before. You could put things in a box, and now the line is wiggly. And you can have psychosis with OCD and depression and all kinds of disorders. So it's not just postpartum psychosis alone, or depression with psychotic features, right? It can be concomitant. It can exist alongside other illnesses or as parts of other illnesses. So it's just not clean anymore.
And I think Emily probably would follow up to agree, but everything you said I is in alignment with what PSI teaches, and I agree with it. And we'll say this, the other full circle part again. I think the important part is, you can hear even in Dr. Birndorf's description, the help seeker needs to know, I'm not afraid of what you tell me. We can treat any of this.
Yeah.
I think that what we did for so long is separate all the perinatal mental health disorders and then psychosis. And every message about that is, we are scared to touch it and talk about it.
Mm.
What we're doing is saying, tell me, because I'm not afraid. We can treat anything you tell me. And so you hear Catherine saying, if there is a change or you are worried, bring it to me right away. I'm not worried. I'm not afraid of it. That means if someone has anxiety with OCD and they're not in danger of acting on it, they'll come to you.
Mhm.
And if it's not psychotic, you'll figure that out with them. If there's delusions, if this person, no one, I don't know anyone as verbal as you, Aaisha. I really haven't met a help seeker as verbal as you, as hard as you tried. But if someone was even a teensy bit like that, you'd learn it, right? Right, Emily? You would hear it. The point is, I'm here for you. I'm not afraid to have you tell me what's happening.
If I could just add to that, and I'm so grateful for the switch that PSI has made in all of that, and it's like so validating, and I would just kind of like to add in some that basically what we're, I think, all agreeing to is the fact that intrusive thoughts, somebody can experience intrusive thoughts and also be experiencing hallucinations and delusions, and that's why it's so important, like, even when somebody is saying that they're afraid of their thoughts and stuff, it's always so necessary to probe to see if there is the presence of delusions and hallucinations. And probing to see if there's delusions and hallucinations doesn't look like asking a person, like, are you delusional? Are you hallucinating? Because a person who's delusional and hallucinating does not know and recognize that they're delusional and hallucinating. They just think this is true. So, and that's also another place where PSI can help, plugging PSI there, in terms of there are ways to find out this information and probe for that information. But particularly if a help seeker has been coming in a couple of times, I think that is the kick in the pants that a provider should have, that you should be now like probing for the presence of delusions and hallucinations, and this is also where information from family will be very useful, that collateral information about, like, is this like person like behaving bizarrely, because that's often a response to delusions and hallucinations. A person will behaving in a bizarre manner, right? So I think all of this is like useful to understanding whether or not it is intrusive thoughts or psychotic thinking. That's the issue. Like, it doesn't have to be as murky. There are tools to help us, like using family information, using collateral information, all this kind of stuff, using your observations, like that kind of thing, to help you determine if which it is, in OCD type intrusive thoughts, anxiety type intrusive thoughts, or actually psychotic thoughts. I hope that's kind of helpful, I hope.
Yes. 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 Thank you, Aaisha. Thank you, everyone, for giving us your time, your expertise, your eloquence. That we're about wrapped up. We're at about at 7:30. So yeah, again, thank you for tuning in. Any questions? Again, PSI we've established is perfect, and you can reach out to us. The website, postpartum.net, what the PSI helpline. Please, please, please reach out if you're concerned or for anything. So thank you, Wendy. And a mom like that, we had put it in the links of how to purchase it.
Thank
can
you so
even
much,
purchase it through our
Wendy,
website.
for
Sorry,
sharing.
Aaisha. Yes. Wrap us up. Anything else you want to say, or?
Yeah, I just wanted to make one quick point, if that's I shared the particular passage that I did because I also really wanted to show how intrusive thoughts and psychotic thinking can mesh together. So if I could just make this one point for people that could stay on for one more minute.
Yes, of
Like
course.
in the part where I was having like those violent urges towards the pregnant passerby, I mean, at that moment, the imagery that I was seeing was clearly intrusive thoughts. I can say that because I remember seeing it in my mind. But I had delusional thinking because I thought the devil put those thoughts in my head. And then I was also feeling like I was being propelled, pushed toward the woman, which was actually a tactile hallucination. So these things can all overlap. They are not like separate things. Like I was having intrusive thoughts, but those intrusive thoughts were connected to delusional thinking and hallucinations. So that's why I think it's so important that that all providers learn about this condition. And it's not enough to be a perinatal like provide a health expert and learn about all the other perinatal mood and anxiety disorders when this is the condition that has a real risk of harm to mom, baby, and others. So that's why I'm so grateful for this opportunity to spend this time with a bunch of experts on this topic. And that's what I really hope that people take away from this, the importance of learning more about postpartum psychosis so that you can be there for every mom. Thank you so much, everybody.
So well said. Thank you, Aaisha. Amazing. You're amazing.
You
Yes,
are
thank you so
amazing.
much.
And we got to thank Dundurn Press too, because if you don't have a publisher willing to publish this,
Oh my God, I got 110 rejections. So I'm so grateful to Dundurn Press.
Wow.
110.
That's a story.
Did you see all of our mouths just open? We're all like, what?
Wendy's is
oh,
still.
also, I was going to say, when Julia asked what stood out to you in the passage,
Yeah.
what was your first thought? Is, dang, she's a good writer. Oh my
Yes.
gosh, it's a beautifully written. So thank you to you, Aaisha, to your family. Thank you to all of you, and to those of you listening. And it's taped, so you'll be listening in the future. We'll still be here.
Thanks.
Bye, everybody.
Bye.
Bye.
Bye, everyone. Thank you to